Good morning, good evening, good night, depending on where you are in the world. We're going to talk about statins and cardiovascular inflammation. We mention that a lot, and for my purpose, the major reason to give a statin is for cardiovascular inflammation. A lot of people ask me about that. The vast majority of the medical community focuses much more on LDL than we do. And as we get deeper into that, a lot of folks will refer our information to their docs. The docs will ask about it. And we'll cover a little bit of that today. Just like anything else, it can get a little bit messy when looking at the science. And one of the things you'll see and we'll mention is that there actually does appear to be some relationship to LDL. At least there has been in some studies. So again, Mark Twain made the comment, or at least he's credited with the comment of saying, those that like sausage or politics shouldn't watch either one being made. And, the point behind that is pretty obvious to most of us. The reason I bring that up is you can say the same about science. It can get a little bit dicey, a little bit confusing, a little bit frustrating sometimes. And that's one of the key things about this channel. We go a little bit deeper in terms of looking at the things that matter to us, the things that change our health. For example, we would say a stress test is not the way to predict a heart attack. That's how it's used, but it's pretty clear that it doesn't do that. We would say statins are really more for cardiovascular inflammation. And because cardiovascular inflammation is a much better predictor of heart attack and stroke than LDL. And we say a lot of things that you just don't hear in standard medical groups from standard medical doctors. Perhaps the most important thing that we come to again and again and again is that there is a root cause underlying most death and disability. And, most death, the number one cause of death is heart attack. Number one cause of disability is stroke. Dementia is a growing cause of disability. And guess what? There's a key root cause for all of them that your typical doctor, the science is really clear about this. Your typical doctor doesn't know how to diagnose it, let alone manage it. And it's very simple. It just takes a little bit of knowledge and a different way of looking at things. And so that's what we'll do. By the way, if you're wondering what that root cause is, if you've seen any of our videos, you know what that root cause is. It's prediabetes. The doctors use a technical term, insulin resistance. That can be confusing if you don't know what that means, but it just means that the insulin receptors in our bodies don't respond well to insulin resistance. So that's what that kind of information is what this channel is all about, because there's a gap. Most people depend on their primary care doc, their internist, their family practitioner, even their cardiologist for prevention. And it's pretty clear that prevention is a little bit deeper than what most non-prevention specialists know and understand. So unfortunately, it's a buyer beware kind of thing. If you really want to prevent your own heart attack, your own stroke, if you want to have a long-term healthy, a few more healthy decades, even though you may be in your 60s or 70s, you need to learn some things on your own. And one of the most important things is, do I have insulin resistance? Do I have prediabetes? If you look at our previous topics, we covered one last week that's a big bugaboo for a lot of folks. There's been tons and tons of focus, and there continues to be a lot of focus on artificial sweeteners. Does that cause prediabetes, diabetes, or insulin resistance? there's just so much connection there. And the question is, do they? I think some of them probably do. I don't think it's as simple as what a lot of people think. A lot of people think stay away from all artificial sweeteners. They all cause it. I don't think that's that clear. And in fact, when you look at the actual science, it's clearly not the kind of risk factor that aging is, clearly not the kind of risk factor that obesity is. And just how much of a risk factor is it? And if it is a risk factor, what causes it? Is it an impact on our insulin receptors, or is it something that happens in our gut? Is it a gut biome issue? So that's one of our previous topics. In fact, we just covered that last week. The week before, we covered vascular function tests. What are they? How do they work? And do they really help you in terms of understanding your risk? We covered that the week before. And then the week before that, we covered sleep. Sleep is going to be like sleep problems. A couple of things over the next decade will become as big as smoking was in terms of cardiovascular risk a decade or two ago, when we began to realize that smoking is such a huge risk for cardiovascular disease. Now we're beginning to realize that lack of sleep, poor sleep, is a major risk for cardiovascular disease. There's some other things too that you might not think about, like sitting, lack of exercise, just sitting instead of standing. There's a lot of things that you just might not understand about having a long, healthy life until you look a little bit deeper. So we talked about how important and how under-recognized prediabetes, insulin resistance is. That's one of our key content points for this channel. We actually have a webinar where you can call in, register with Michelle, get the get the definitive testing, and then work with a group of us to find out, do you really have that problem? I still have a little bit of throat issues from the past month, so please be patient with me. As we discussed, there's some core content that we provide that you're just not going to get from your typical doctor. Insulin resistance, what causes it? What is it? How do you diagnose it? What do you do about it? Cardiovascular inflammation. Again, we'll talk about that some today, but we have a course on that. And plaque, how do you evaluate plaque? Do you do like Tim Russert did and said, hey, doc, I'm having some problems. Can we do a stress test? You know what happened with Tim Russert? He passed his stress test with flying colors. And then he had a heart attack and died. Things are, oh gosh, I hope I don't start getting into that cough, this coughing habit. Talking is a stress for me right now, so I'll try to move quickly. Things are moving very, very quickly with Jubilee. It's our program down in Lower Alabama. We started with one clinic. Now we're at 3. We just started a new clinic last week, and we've got 3 other clinics in Alabama which are very interested in joining the group. We're having a series on the prevention myths, things that your typical doctor doesn't understand about prevention. This one focusing on stress tests, evaluation of plaque, the sort of tests that do help you understand your risk for heart attack, and why having a stress test really doesn't help that much. Now, I wanted to cover, one of the key things that any content group should do is cover errata or errors. I misspoke, a few weeks ago about the half-life of levodopa. Now, why is that an issue? Number one, Livalo is the only statin that does not increase the risk for insulin resistance. So it's a very important statin, one of the two most important ones available right now. The other thing about Livalo, the other thing about Livalo is it's very expensive because it hasn't lost its patent. And the makers know, yeah, it does not cause insulin resistance. So a lot of folks have an interest in pitavastatin. So it's expensive. It doesn't cause increased risk for prediabetes. So why is the question about the half-life a big issue? Well, the other very important statin out there is rosuvastatin or Crestor. Crestor has a half-life of 17 hours. So therefore, it makes sense to use Crestor every other day. And some folks even use it once a week, low-dose Crestor. That has been shown to have an impact on cardiovascular inflammation. Pitavastatin has an impact on cardiovascular inflammation as well. We tend to not use it with these longer doses every week, 2 or 3 times a week. It does have a shorter half-life. I think I mentioned by mistake a few weeks ago that it was a 4-hour half-life. That's not correct. It's a 12-hour half-life. We do have a couple of people that take pitavastatin every other day, but I don't really recommend it. There's just not enough science behind it. And again, 12 hours is significantly shorter than the 17. So I've had a lot more people ask me about every other day or twice a week pitavastatin than are actually on it, again, because of the discussion that we just had. So what is half-life? It's the time that it takes your body to excrete half of a drug. And that's half-life is how we always look at how long a drug stays in the body, or a poison, a drug or a poison. The half-life, as I said, for Crestor is 17 hours. The half-life for pitavastatin is 12 hours. It reaches its peak plasma accumulation within 1 hour after initial dosage, and 79% of it is excreted through the feces and within 7 days. Now, I know I made a comment about it sounded like I was equating drugs with poisons. If somebody has an interest about that, leave us a question and we'll talk about it during the Q&A. So let's go ahead and talk about statins and cardiovascular inflammation. You want to give us the water ball? So Dr. Jesus covered some separate items. As I mentioned before, we get a lot of questions about cardiovascular inflammation. A fellow named Paul Ridker, and Gavin Blake started looking at studies, over 10 years ago, 20 years ago now. And they started noticing that people on statins, in these large studies, people on statins had less risk for heart attack. They had decreased heart attack rates, even if their LDL started lower and went up if they were on the statin. Now, that's not common, but it happens. It also seemed that there were a lot of people, again, like this group, where it really didn't seem to matter whether their LDL went up or down. If they were on a statin, they tended to have a decreased risk for heart attack. So they started looking at it. Paul Ridker, Gavin Blake, a couple of smart guys at Harvard. And they started saying, and they weren't the only guys, they got a lot of the the credit for it. And they did. It was well-deserved. They moved this question forward in the science a lot. Now let's talk about C-reactive protein. Most of these studies were done with C-reactive protein. And let me get to the script here. In terms of background, inflammation is critical in the formation of plaque, or athero, meaning plaque, sclerosis, narrowing of the arteries. And again, that's a misnomer, because it's not so much narrowing of the arteries. That's what we always thought, that we, meaning the scientific researchers. Now it's understood a little bit better that it's not a narrowing process. It's more this inflammation process, which we'll discuss. An elevated level of C-reactive protein, CRP, an inflammatory biomarker, is a strong predictor of future cardiovascular events, even more so than LDL. In two meta-analyses, remember meta meaning larger focus. In other words, a meta-analysis, if you haven't spent a lot of time on this channel, you may not know what that means. A meta-analysis is a study of studies. You go in and you look at the science, and you look at all of the studies that have been done on a specific topic, and you analyze those to see how strong the case is for that specific topic. And in this meta-analysis, they were talking about, excuse me, how about cardiovascular, how about cardiovascular risk and cardiovascular inflammation? How does that compare to LDL? So in two meta-analyses, they saw strong positive relationships between changes in LDL and C-reactive protein. In other words, there seemed to be some correlation, and maybe LDL was a marker of inflammation. Maybe inflammation was a marker of LDL. So again, that raised questions. But inflammation is central to cardiovascular disease, and C-reactive protein changes might be independent. That's really the question. Is it independent? And that's where the story that I told you about Paul Ridker and Gavin Blake and some of the research that they did began to tease this out. You saw that with the Meteor study. That was one of the first studies that really started to make more of an impact on this question. Here's the information and the authors on the Meteor study. Objective and methods. They were investigating the relationship between C-reactive protein lowering effect of rosuvastatin, Crestor, and reductions in LDL causing measuring effects of intima media thickness. Again, that was some of the words that created the term, the acronym Meteor. The study compared rosuvastatin versus placebo in the treatment of 984 individuals with moderately elevated cholesterol levels in coronary heart disease during a two-year period. The results. Rosuvastatin was associated with a 36% decrease in C-reactive protein, a 49% in LDL, a 34% in total cholesterol, and a 16% in triglycerides, and an 8% increase in HDL. As you might imagine, as you look at individual patients, especially LDL, sometimes you can actually see a decrease in HDL associated with statin use. So something to be aware of on an individual patient-by-patient basis. In this study, the Meteor study, there was no correlation found between C-reactive protein change and LDL reduction. So are those two bullets, they sound like they're mutually exclusive. They're not. Again, you do see decrease in LDL with statins routinely, and you'll see decrease in C-reactive protein, as well as the other cardiovascular inflammation markers. When you start analyzing individual patients, it's not always the same patients. These two things tend to happen independent of each other. C-reactive protein, CRP reduction was more evident in men over 60 years old. And it was also more evident when the baseline CRP was elevated. We got a couple of typos there. Thank you for your patience with us on this. Here's some other studies that got deeper into this question. Jupiter was a very well-known study in this space. The Prove It, Timmy studies, several studies. So the data in this study demonstrated that statin-mediated reductions in C-reactive protein are unrelated to the decrease in LDL and other lipid levels. Statins have a variety of pleiotropic properties. You remember that term? Again, it's a 50-cent technical term. And the key way to remember that is to think about those of you who remember the Pleiades. That's an astronomy term. It's a group of stars, a cluster of stars that goes back, like many of these, to Greek mythology, the seven sisters. Pleo just means many, and tropic means going towards. So the bottom line is statins have been discovered to have pleiotropic effects. In the beginning, it was known that they lowered LDL. It was not known that they actually had a different impact as well, independent of that LDL impact. And that impact was decreasing inflammation. One of the things that even doctors who began to learn this content get a little bit confused by asking, well, what is cardiovascular inflammation? It's the same as inflammation that you find in any other part of your body, except it's specific to plaque. Your own immune system will attack plaque in your arteries. When it does, it softens it. The goal is to reverse and get rid of that plaque in your artery wall. It does actually soften that plaque. When it does soften the plaque, that plaque can actually seep through the lining of the artery wall. If it touches blood, liquid flowing blood, it'll cause a clot, or it can cause a clot. That is the actual mechanism for heart attack and stroke. So that helps to explain why in the introduction of this video, somebody like Tim Russert can pass one of the reasons why somebody like Tim Russert can pass a stress test and then turn around and die from a heart attack. This is not just plumbing where you're squeezing. Remember we talked about the term atherosclerosis? It's not just squeezing the lumen or the flow of an artery. It's something different. It's inflammation attacking the plaque, and the plaque causing a clot because the inflammation softened it. This result, impact of the statins on C-reactive protein and cardiovascular inflammation, is consistent with findings seen in multiple studies, which you see here on the right. The Prove It Timmy 22 trials, the reversal trials, the Jupiter trials. Rosuvastatin independently lowers C-reactive proteins, again, independently from its impact on LDL. So that was our content for today. Again, if you'll get us the water ball or whatever we're using for Q&A, we'll go ahead and do that. So we've got a lot of folks on. We got a lot of questions. Hopefully I won't end up having to end early because of my continuing respiratory stuff. I was seeing a patient today. He was considering whether or not to take an ACE inhibitor, and I was coughing a little bit then, and he said, I think he really didn't have a strong case for it. He was, for his blood pressure was fine. But he was interested in it, and he knew that that's one of the side effects of ACE inhibitors is to make you a little bit more susceptible to coughing. And it's so funny because I'll talk to people, I'll give presentations and I'll say, I do recommend ACE inhibitors. Sometimes it can cause a little bit of a cough. When I'm going through a respiratory problem or have had one recently from allergies, or maybe recently from a cold, or maybe even a version of Omicron. Instead of just getting over it in 4 or 5 days, it can take me a few weeks. But again, I know the impact that ACE inhibitors have on this issue. One of the things that happens is that the addition of ACE inhibitors to statins doesn't have an additive effect on cardiovascular inflammation. It has a multiplicative effect. So it's not like 2 + 3 = 5. It's 2 × 3 = 6. It's a much bigger impact. And I do have cardiovascular inflammation. I have plaque. I've told my story several times. In fact, one of our most popular videos is how, when I bit the bullet, I'm not a statin lover, by the way. I didn't personally want to start statins, and I was delaying that some. And when it became really clear that I had plaque, after some time, a couple of years actually, I finally decided to go ahead and start taking statins. That had a big impact on my plaque. Now, you'd ask the question, did it actually reverse it? Well, that's the term we used. But again, once you understand the microscopic, what's actually going on with cardiovascular inflammation, what you see is that you decrease the inflammation, you decrease that fluid that's in there, making it a hot liquid plaque. You decrease what things we call cytokines. You decrease the immune cells. As you decrease all of those, the plaque, as measured by CIMT, shrinks. I'm not the only guy that talks about that. You've actually seen, there've actually been some comments on that on Harvard Health for men, something written routinely at Harvard for patients. Okay, so Fort Worth West Side. Good morning, everyone. Bart Robinson, looking forward to this topic indeed. So thank you guys, I appreciate it. Margaret D, we'll catch up on it later. Margaret's going out for a swim. So go, good for you, Margaret. Go for it. Fort Worth, what makes Crestor different from the other common statins in regard to inflammation? Are there some of the others just about the LDL only? That's an interesting question, Fort Worth. And one of the questions I get has to do specifically with the most popular statin. It was the first big one out of the blocks, Lipitor. I don't use Lipitor. And the reason I don't use it is that it's been shown to have less of an impact on cardiovascular inflammation if you're a female or if you have prediabetes. Well, if you're a female, that's automatically half the population. If you have prediabetes, that's 80% of us. So, yes, Lipitor works for cardiovascular inflammation, but for only about 20% of us. It still works for most of us, but it doesn't work nearly as well. People challenge me on that. There's not a lot of research that shows that, but there is research out there. There's clearly evidence, and it has, you got to know what to look for. So I pulled that up recently and sent that to Jesus, and I think we'll be covering it in a few weeks. So Margaret D, question, if it comes up in discussion, if statins reduce heart inflammation, do they also work in other parts of the body for inflammation, lungs and muscle? How does this EXP muscle pain? Oh, explain muscle pain. So two different questions, both of them very appropriate for this issue. The first one is, this is cardiovascular inflammation. It's not really clear why it works for that, but not other areas. If you go back to that researcher that I talked about, Paul Ridker, he's continued to do tons and tons of research on cardiovascular inflammation. The COMPASS trial, for example, was looking at a specific new type of injectable anti-inflammatory. He's looked at colchicine, which is an anti-inflammatory. He's looked at, non-steroidal anti-inflammatories. There are tons and tons of different types of medications that have anti-inflammatory effects. But colchicine didn't work. Non-steroidals clearly don't work. They work for other types of inflammation, not cardiovascular inflammation. So one of the things that's really, really clear is that cardiovascular inflammation is different from joint inflammation. It's different from lung inflammation. It's different from other types of inflammation. I mentioned Paul Ridker and some of the studies that they were doing. There's a drug. It's a biological drug, and it's for a specific type. It's an anti-inflammatory. It's called canakinumab. He looked at that in a large global trial of cardiovascular inflammation and risk management. They actually saw a decreased risk in heart attack, and that came from the decrease in cardiovascular inflammation. But about as many people as they saved from cardiovascular inflammation, they gave up in decreased some problems with infections, things like that. So you have to remember things like steroids, non-steroidal anti-inflammatories. These things can also decrease your response to inflammation. So inflammation is there clearly for a purpose. The inflammation I've had after my upper respiratory infection, that's inflammation where my immune system wanted to fight that virus that started this. The inflammation with cardiovascular inflammation is where your immune system is recognizing plaque in your artery wall. And it says, that plaque should not be there. That's not healthy. We want to get that plaque out of there. So it sends cells in there. The cells release things called cytokines, cyto meaning cell, kine meaning attractants. So it attracts more inflammatory cells. They also release things like enzymes, which cause it causes the plaque to go from a stable, hard, waxy substance to a liquid substance. That would work in terms of clearing that plaque out. But again, unfortunately, that's what causes the clot if it seeps back through the lining of the artery wall. Fort Worth, since statins interfere with its production cycle, should one take CoQ10 supplement even if taking 5 to 10 milligrams of Crestor? Yes, we've covered that multiple times. I always recommend taking CoQ10, especially if you're on a statin. It gets back to that quote about sausage. If you want to understand exactly what's going on with CoQ10, that gets a little bit messy. So CoQ10, instead of having a lot of hard science that shows, yes, it really helps if you're taking a statin, it gets back to one of those supplement things that, yes, there's logic behind it. The science is a little bit more difficult, and it's because of what CoQ10 actually impacts. It impacts mitochondria. It impacts the actual production of energy within the cells. I just remembered that I forgot to cover Margaret D's last question. How does statins explain muscle pain if they decrease inflammation? Well, the muscle pain associated with statins, is not an inflammatory type of pain. It does appear to have a little bit more to do with what we just talked about, energy production. Now, before I go too deep, though, I will say this. I've had my own muscle pain, and it came at times when I was taking a statin. The association between muscle pain and statins is not nearly as strong as most people think. In fact, if you actually go deeper in terms of the research, most muscle pain does not really respond to stopping statins. They've done plenty of studies where people said, oh, I've got muscle pain. It's due to the statins. I need to stop it. They did plenty of studies where they actually did that with a placebo. And the reality was it didn't change the muscle pain. That's not saying that it never occurs. It's saying that it occurs a lot less than you might think. When I did have my own muscle pain, it was predictable. It was my weekly hard run. There was a hill run that I did at the end of my distance run, and coming back down off that hill, about 9 times out of 10, I'd start getting a cramp in my calf. And if I just walked myself through it or jogged through it, I would be fine. And no, I did not stop taking my statin. Fort Worth West Side. Well, we just talked about that one. Melissa McKenzie, these medications are causing cancer. Melissa, I would challenge that and ask you, it's easy to say something causes cancer. Breathing causes cancer. Can you actually show us the data? That does bring up a point. You remember I mentioned the term about half-life, and I was talking about, I use the term poisons and medications in the same breath. I used to do a lot of work with occupational medicine, and in occupational medicine, the roots of occupational medicine, working with people that were working in environments, had to do with exposures to poison. So a lot of what I did was, I was certified in that space, and a lot of what I did was basic toxicology. As you get deeper, toxicology is the medicine associated with poisons. As you get deeper into toxicology, you realize that there's not many things that are not poison, not many things that can't kill you. For example, air can kill you. Believe it or not, yep, an air embolus, air in the blood, directly in the bloodstream, can kill you. So air in the wrong place at the wrong time is a poison. Water, we know, is a poison. Water filling the lungs will kill you. So by definition, you have to get a little bit deeper in terms of understanding what's the right place, the right time. So therefore, if air and water can be poisons, obviously any medication can as well. So that's where you get some of the linkage between medications and poisons. Bart Robinson, Fort Worth, I would say yes, absolutely. And I think what Bart was talking about was Fort Worth's question about should you take CoQ10. I would agree with you, Bart. Max Bet just got back from hospital. Second stents placed after second heart attack. I'm listening very, very intently, Doc. Thank you so much, Max. And I don't know if now's a good time to make this comment, but I will. Some of the things that we have a very, very different look at are stents. About 90% of stents are done to prevent a heart attack. If you look at the Orbiter trial, the Courage trial, the ischemia trials, they make it pretty clear that stents don't prevent heart attacks, despite what your interventional cardiologist may believe. And again, as I said, I may sound like one of those crazy internet docs, but these studies, this science was very well respected. It was, these things were published in the leading journals in the world for medicine, the New England Journal, JAMA, Journal of the AMA, Lancet, big journals. And so you really, if you have more interest in that space, look these up on my videos. Stents, does stents prevent heart attacks? Now, every time I mention that, I get people that say, wait a minute, that stent stopped my chest pain. I'm not going to get in. I've seen stents where they clearly did look like they stopped chest pain. I'm not really talking about that. I also feel the evidence is very, very clear. If you are having a heart attack, quite often a stent is a perfect treatment for it. Quite often they can actually remove the clot with a stent placement. So stents can save lives. But let me go back to what I originally said. I'm not saying a stent's not going to get rid of your chest pain. I'm not saying a stent is not going to save you from a heart attack. What I said was stents don't prevent heart attacks. And guess what? 90% of stents are placed to prevent a heart attack. So thank you again, Max. You brought up a great topic. And I don't expect everybody in the world to agree with what I just said, but I'm not, I'm just quoting the science. Go take a look yourself. Alan Turner, what dosage of Crestor is sufficient to decrease inflammation? Is 10 milligrams daily or 20 milligrams daily too much? For me, yes. I rarely recommend going as high as 10. Excuse me. My standard dosage for Crestor is 5 milligrams a day. Which statin works as well as Crestor for inflammation. Some others do. Simvastatin works well. Pravastatin works well. As I mentioned, Livalo or Pitavastatin, the generic name. These are all good statins. All of them have a little bit better cardiovascular inflammation profile than Lipitor. And Lipitor's generic name is atorvastatin. Someone just gave us Parker Reed just gave us a $10 super chat. Thank you so much, Parker. Again, a couple of points about the super chats or these donations. They make a difference. I currently support the channel. The vast majority of my support for the channel comes from me seeing patients, my own work. People are watching this content from all over the world. About half of it in the United States, a little bit less than half folks are in the United States. The rest of it comes from, again, around the world. Our own staff, for example, Gilbert, who's on co-hosting with me, Gilbert's in the Philippines, and that $10 that Parker Reed just donated goes a long way in a Philippine economy. And as you might guess, by definition, if you're here watching the channel, you realize that this is life-saving information. So, Parker, you just had an impact on getting life-saving information out there. And that's not the first time for Parker. He's provided some content, provided a lot of good reactions and information. So I think we'll be looking forward to having Parker actually appear on the channel at some point too. Thanks again. Gator Beer Geek, thanks for all your info. Could I suggest a video topic be secondary prevention concerns? For those of us who have had MI, are there more things we should look at outside of normal prevention topics? Well, thank you so much. That's a great point, Gator Bear Geek. And let me just make the point. So you get into this whole thing about secondary prevention. There's some confusion and some debate about secondary versus primary prevention. So why does that matter? Well, it became an issue with things like aspirin, baby aspirin. They just said, we don't recommend baby aspirin anymore for primary prevention. Well, what does that mean? Primary prevention is you don't think somebody has any cardiovascular disease. You see, primary prevention is prevention before somebody has disease. Secondary prevention is somebody has disease and you're trying to prevent it from continuing to get worse. Now, Gator Bear Geek, here's the thing about primary and secondary prevention, and here's why it matters, and we'll use the aspirin as an example. I never recommended, for the past 10 years, the past decade, I've not recommended baby aspirin for people that didn't have plaque, and no matter what their age was. So you saw some primary prevention recommendations based on age, 60 or 65, take baby aspirin. Now, most 60 or 65-year-olds that I am seeing I have recommended baby aspirin for, but it's not because they were 60 or 65. It was because we were already in secondary prevention. Now, here's the other distinction. You're making an assumption that secondary prevention is only after you've had a heart attack. I'm saying, no, secondary prevention is actually once we find plaque in your arteries. At that point, we know you've gone down that disease process. Your root causes have already resulted in you laying down plaque. Laying down more plaque, getting inflammation. You're not going to lay down any plaque unless you're starting to get inflammation. And the end product of that is, inflamed plaque, that plaque leaking into your bloodstream, and you having a heart attack or stroke. So once you've got plaque, at that point, I would call it secondary prevention. So after you start looking at that, Gator Bear Geek, the reality is the stuff we talk about on the channel, there are some significant distinctions. All of the lifestyle stuff, you want to keep a minimum of body fat. You want to keep up your muscle content. You want to decrease carbs. You want to know if you have a carb metabolism problem. Here are the distinctions. I don't recommend baby aspirin if you don't have plaque. So no disease, no baby aspirin. No plaque, no baby aspirin. If you have plaque or if you've had a heart attack, I recommend baby aspirin. Unless, of course, you have atrial fib or something like that, in which you need something different from baby aspirin. You need what we call a NOAC, a novel oral anticoagulant, like rivaroxaban, Xarelto, Eliquis, that sort of thing. The other major distinction between primary and secondary is the topic that we talked about today. I don't recommend statins if you don't have plaque. If you're I've got 65-year-olds, 69-year-olds, a 70-year-old or two even that don't have any plaque. If you don't have plaque, I don't recommend that you take a statin. So the key distinctions between primary and secondary, in my mind, are not whether you've had a heart attack or not, but whether you have plaque or not. And the key distinctions between what you should do differently are statins and baby aspirin. Great question, Gator Bear Geek. Gator Bear Geek. Thank you so much. Bart Robinson, I take 5 milligrams Crestor, sometimes every other day. LDL was never high, even before statins, but had a 500 calcium score 6 years ago. So Bart's a good example. About half the people that have a heart attack have normal LDL levels. So again, that just doesn't fit with that being the root cause, does it? So Keanu Dirk. That looks like it might be one of the Filipino languages. I don't know. Freedom Fox 1. I'm curious to hear about your opinion on the probiotic pendulum, which is demonstrated to lower hemoglobin A1C in people with diabetes. I'm not familiar with that brand name. Sounds like a brand name. It seems to work by lowering inflammation and raising butyrate levels. Not familiar with that, but I would say if something clear, and I will also approach anything with skepticism. I would approach that with skepticism, but I will say this: if it clearly does decrease hemoglobin A1C. I'm probably going to be a fan of it. Excuse me just a minute. Okay. John Tocho. I also take 5 milligrams of Crestor every day. If I forget it at night, then I don't worry because of the half-life. One of the first things I do with meds is look at the half-life. Excellent point. And you know what? How many patients, how many people just off the street know what a half-life is, let alone like John, knowing to look at a half-life and think about that and what that means in terms of dosage. So, John's just a good example of, you tend to have some very smart people watching this channel. We got a lot of docs, a lot of healthcare professionals, a lot of dentists, a lot of folks that do know a lot, getting a lot of information and getting that prevention information out there. Walter Ski, my primary care doc, poo-pooed C-reactive protein as a predictor of anything a decade ago, since he had patients with low CRP and still had heart attacks. He stopped doing this test. That's unfortunate, isn't it? Thanks for sharing. And it's, it brings up the point. And doctors, and I am one, I've made a living of supervising docs and healthcare providers. I have to tell you, they say you got to be pretty smart to get through med school, and it's true, you do. I would say you have to be able to tolerate a lot of work. That's true. That's more true than having to be smart, I think. Because when I look at docs, it's so weird because I'll see them, they don't tend to understand statistics or epidemiology at all. They see one example of something happen and they think that proves something on a population basis. Gator Bear Geek, when you mention CRP being a better indicator of risk than LDL, is that both standard CRP and HSCRP? Is one a better predictor? No, I would focus on HSCRP. Now, for the rest of you, you're saying, what is he talking about? Thanks for bringing it up, Gator Bear Geek. And pardon me when I keep calling you Gator Bear Geek. I'm sure you've had that before. So anyway, the HS stands for high sensitivity. It's just a better test. And that's what we use. Bart Robinson, good point. John. Brendan Lenane. Recently retested LP-little-a, was 66, down from 178 a year ago. Congratulations, Brendan. And for those of you who don't know what LP-little-a is a genetic variation of LDL. It does appear to be significantly more, cause more cardiovascular risk than LDL. And for those of you who haven't heard of it, dang, I had that name on the tip of my tongue. Who was the trainer that had a heart attack? I talk about him a lot. And LP-little-a became ready for prime time at that point. He was the trainer on The Biggest Loser. Bob Harper. I think it was Bob Harper. So if you don't know about the LP-little-a story, take a look at some of my videos on LP-little-a. One other thing I'll say about LP-little-a before I finish Brendan's question or comment is that, it's a typical thing. Cardiovascular risk is multifactorial. Many things can cause that risk. LP-little-a is one of them. Given what I do, I have a lot of people with high levels of LP-little-a. There's a French-Canadian gene pool where these folks have 350, 400, 600, 700. They have calcification of the aortic valve associated with this. And I can tell you, and there's a LP-little-a research group and a patient group on the internet. Cardiologists in the standard medical community used to ignore it because they didn't know what to give for it. Niacin actually helps. And niacin in and of itself is a whole different challenging science story. I've got a series of videos on that. When Bob Harper announced that, yeah, I was 50, I was well known for being a health nut, a trainer, and yes, I had a heart attack. It came from Lp(a). Then people began to talk more about it. Another big thing, perhaps one of the biggest things for Lp(a) that's come up over the past few years is a new drug class. It's called antisense drugs. For people that are worried about messenger RNA and calling it a genetic drug, you know, the antisense drugs, very, very similar mechanisms. Not going to go any deeper on that comment, but the antisense drugs for Lp(a) have had huge impact. I will be very surprised if they don't come out being a major, significant treatment mechanism for Lp(a) for the future. Anyhow, back to Brendan's comment. His Lp(a) was 66, down from 178 a year ago. He's been taking the half a gram of niacin, 5 milligrams of Crestor and berberine daily with a lower carb only. Is this drop possible? Of course it's possible. I see that all the time, Brendan. I think mistake, high C-reactive protein under 0.4. Maybe you meant to, maybe your machine auto-corrected. Maybe it was HSCRP now under 0.4. But 0.4, that's great. Winona Shopping. Erland FR, good to hear from you, Erland. Hi, Doc. You mentioned that your BG will go down after exercise. I think you're talking about blood glucose. Mine goes up. Any idea why the difference? For the most part, blood glucose will decrease after exercise. All you have, the people that, I'm a big fan of using continuous glucose monitoring because prediabetes, diabetes is such a big unrecognized issue. And when I put people on that, you know, while I'll do a quick rant and rave about the FDA requires a prescription for Libre and CGMs, continuous glucose monitors. And to me, that's in the face of a prediabetes epidemic causing heart attack and stroke epidemics. I can't understand why the FDA would be so dumb to do that. Anyway, so Erland, the vast majority of folks will get a decrease in blood sugar when they walk because exercising muscles bypass failing insulin receptors. But not always. You know, it's just like everything's always so complicated. The reason some of us can get an elevation is when you start doing significant exercise, you'll get that epinephrine, that adrenaline, that fight or flight mechanism going on. And epinephrine will cause your liver, or adrenaline causes the liver to release blood glucose by cleaving glycogen within the liver. So that's why you'll see that. You'll typically see that in folks who are on a low carb or keto diet, and they've decreased a lot of their body fat, and they tend to have a little bit more of a high revving fight or flight and glucose metabolism. Do not be worried about that causing risk. I've been in, when I get in a little bit better shape, I start getting the same thing, especially when I exercise hard. Fort Worth, you recommended 5 milligrams per day, which I take. What's the downside of one taking 10 to 20? Well, again, rosuvastatin in those higher doses, 10 to 20, can actually, again, push you down that prediabetes highway, causing increased insulin resistance. Increased side effects like rhabdomyolysis. Yes, and the higher doses are, again, the higher doses of any of the statins are a little bit higher risk for rhabdo. But that's unusual. Again, the bigger, very common risk is increasing insulin resistance. Mike Carroll, I'd used Crestor before a problem with my muscle pain on diltiazide and metoprolol, low dose pre-diabetic numbers, slight high. Any recommendations? I don't really, number one, I can't diagnose and make recommendations on a public channel like this. And number two, I have to get a lot deeper in terms of understanding exactly what's going on. You run a channel like this and you get a lot of folks that'll give you 3 or 4 different unique things that's going on with themselves and expect us to give us recommendations. I can give you generic recommendations about when to take a statin, when to be worried about a statin, things like that, but I can't give you an individual medical recommendation, Mike. Sorry about that. Freedom Fox 1, do you consider ACE inhibitors better than ARBs? Yes, they are better. It's like everything that's coming up today is one of those major debates in the science. There's a lot of folks that would debate that ARBs are as good. They're not. How much difference is there? It's not huge. I used to take an ARB, and if I get into too much problems, ACE inhibitor related for my own coughing, I might go back to an ARB. But I've had allergy problems my whole life. I can tell you, my coughing problems are not ACE inhibitor issues. John Tocho, Brendan Lenane had very similar results, and my triglyceride also went below 60. John Campbell, hey doc, thanks for doing this. How does the 2K niacin compare to a statin? It helps. So he's talking about 2,000 milligrams. That's that a lot of doctors are aware of niacin having a positive impact, and they're usually when you have a doctor that knows that, they're thinking more in terms of LDL. Niacin is one of my 2 biggest supplements. Niacin is the only thing that'll tends to raise HDL, decrease triglycerides, decrease LDL, but it also pushes you a little bit down that prediabetes highway. Now, of the doctors that know about this, most of them will say, oh, it's got to be 2,000 milligrams. The reality is that's not true. I've got a lot of folks on even, I'll typically see problems at, are people changing at 500 milligrams. I've seen people have an improvement at 250 milligrams. And the reason I see these earlier than other docs who've only seen them at 2 grams is that I'm looking at things like cardiovascular inflammation. I'm looking at C-reactive protein, microalbumin creatinine ratio, things like that. Myeloperoxidase, LP-PLA2. John Tocho, although my C-reactive protein is not as low as yours. Sorry about that. So, again, it looks like folks dogpiling but I will tell you that working with some of my Filipinos, I wonder if that's some Filipino comments. And we do have I think some of it's because we've had so much staff in the Philippines for so long. I think that may be where that's coming from. Winona Shopping. Okay. Erland, please explain the difference between HSCRP and CRP tests. Also, is one better than the other? HS stands for high sensitivity. I'm not going to go deeper in terms of the technology behind the high sensitivity test, other than just to say it's a better test. It's higher sensitivity. Focus on that test. Look at that one, not just the regular C-reactive protein. ECT Global, Atlanta, what about the process of atherectomy to remove the plaque? Possibly considering, just your thoughts. Have a calcium score of 500. There's been a lot of studies about atherectomies. In fact, I trained in medical school under a fellow named Louis, oh gosh, I forgot his last name, but he was known as the carotid endarterectomy doctor in the whole Charleston, South Carolina area. Louis P. Jenkins, was it Jenkins? Anyway, you'll find people occasionally do carotid endarterectomies. Carotid is this artery right here. And they thought they could find plaque in the carotid artery and go in and take that plaque out, and that would decrease strokes. Go ask people. Find out how many people have had a carotid endarterectomy these days. Not very many. And you know why? Because it doesn't work. It's been demonstrated time and time again. Plaque removal, or atherectomy. Athero is plaque, ectomy is to remove. Just doesn't work. Fort Worth West Side. What's the expression? The poison is in the dosage. Exactly. I would also say, you can get a little bit more accurate and a little bit more technical. It's also in the type of exposure, like we talked about water. If it fills your lungs, that's a type of exposure. Parker Reed, apologies for the layman's perspective. Sounds like this boils down to the root cause. An anti-inflammatory diet, exercise, etc. Statins can be minimized as you reverse things that drive cardiovascular disease. Exactly right. Very good point, Parker. Thank you. More dipologue, I think. Jimmy, rosuvastatin calcifies soft plaque. That's correct. Yes, that is correct. If it's calcified, then it can still be reversed later, or is it optimal to have calcified plaques? I've actually had several patients who reversed calcified plaque, and you tend to think that does not happen. Calcified plaque is stable. I mean, we've done, if you don't believe that, I've got a video on that. It's the Honda study, HONDA, like the card. And it was really clear. It showed what we all know. When people decrease, they get their lifestyle intact, they take statins, they get done what they need to do. That soft plaque will become calcified, and we know that it will be stable. And there's studies that have demonstrated exactly that. It's not common that you actually reverse calcified plaque, but I've got a few patients that did it. John Lorscheider did it. Clearly, he decreased his calcified plaque by like 50%. Jerry, I'm blanking on Jerry's last name right now. Jerry Kurth. And both of them came on the channel to talk about that. Parker Reed, $10 super chat. Thank you so much, Parker. Folks, we have a huge number of comments. I can just warn you, I'm not going to get to all the questions today, but I will get to as many as I can. Parker Reed, can I encourage everyone to contribute at least $5, $5 to $10 to help offset Dr. Brewer's cost? Thank you so much. I do appreciate that, Parker. I originally came on with these. I'd print off these PowerPoints, and I'd show them in front of and people made so much fun of me. And you didn't get people really like the way production is done. So Gilbert, for example, who is helping us today, is a fantastic graphics artist. You look at the graphics, that comes from Gilbert. And Gilbert, if you'll say hello to the crowd, I think they'd appreciate that.
Hello, everyone.
So thank you, Gilbert. Gilbert is our co-host usually, but he's also the guy responsible for all those great graphics that you see. Aspen does we get more and more comments about the high quality of the video editing. We've got a doctor on our staff other than me, Dr. Jesus, that we mentioned a couple of times. Dr. Jesus is a public health doctor that's worked with a friend of mine here in the United States, but Jesus is in Mexico. He's working on our content. So again, there's a lot of costs associated with it. We try to manage it by offshoring to less expensive global communities where possible. So again, these things make a big difference. Thank you so much, Parker. I appreciate it. Jan Ling here in the UK, United Kingdom. Thank you so much. Jacqueline Shavara DePiro, 25-year-old with LDL of 145 and LP(a). I think that's LP(a), 142. Should I take statin? Great question. Most people would say you have some significant risk there, but I would say I work with that stuff all the time. And I don't see people develop plaque until they have insulin resistance. So here's two things I would do, Jacqueline. First, I would assess the situation. And the two things I would do, a Kraft insulin survey, that'll tell you whether or not you're burning the inside of those artery walls. Because if you're not burning the linings of your artery, you're not going to develop plaque. So the second thing I would do is get a CIMT. So I would get a Kraft insulin survey or a CIMT. Or, excuse me, and a CIMT. John Cantrell. Oh, I think I said Campbell earlier. John, pardon me. John Cantrell, $10. Thank you so much. We appreciate that. And again, I appreciate folks thinking enough about what we're doing. As you see, we're getting some global uptake of this information, which is information that you're not going to get from the vast majority of your docs. Jesbo W. Here in Oz in the wee hours of the morning, love the channel, Doc. Thank you, Jesbo, and have a good morning there in Oz. Bill Ryan, please tell me you don't have COVID. Bill, I think I've had COVID probably 3 times, maybe 4, because the first time it was this past summer. I was fully vaccinated, went with my son to Colorado, shared that with folks. About a week after after the first flight, I came back with a cough, upper respiratory. And during that, for the first time, maybe the first time, only time I've ever noticed it, I had this weird taste in my mouth. I didn't get, I kept thinking, I need to go get tested. I didn't. I did what I needed to do. I did some quarantine, but not a whole lot. I went ahead and had my booster shot, and we were treating a lot of folks in Alabama with COVID, especially a couple of weeks ago. I had already, about a month and a half ago, I had an upper respiratory that has lasted 3 or 4 weeks. And a couple of times I've had some upper respiratory things that had that weird metallic, oily taste and smell. And again, didn't go so far as to get tested. At this point in time, I think we're all, this last episode with Omicron, I'm going to have to say this. I said this early on. I said, this is not the first pandemic I've worked through. The bird flu, the swine flu, several other pandemics. And one of the things that you tend to find with all of them is that these viruses will mutate. And usually the viruses mutate to things that are more effective from a virus perspective. Well, what does that mean? Well, you spread to more people. Well, how do you spread to more people? Well, first of all, you cause less symptoms because they don't isolate or die, or if you get real sick, you have to go to bed, you're not going to spread the virus as much. So the mutations tend to make a less virulent virus in addition to much more rapidly spread. At this point, it looks like we've got Omicron out there, and sure enough, probably a lot less virulent and clearly more infectious. And so I'll make one more comment about it, and then I'm going to move on. From an epidemiological perspective, that's what you see. And it also sort of becomes an issue. We get so much argument about vaccine. Everybody's going to get vaccinated with Omicron. You're just going to get exposed. If you think you're not going to get exposed, good luck to you. So, Peter Liness, good morning, Dr. Brewer. Malcolm Kendrick in his new book, The Clot Thickens. Interesting, neat topic, or neat title. Has an elegant new theory regarding plaque formation. I'd be very interested in your views on this theory. I haven't read the book. Thank you so much, Peter. I appreciate it. And Peter, if my memory is correct, are you from New South Wales? Be interested to find out. Wade Hampton, I wonder about inflammation and small but daily alcohol intake. Is it a plus or a minus? There's been back and forth on that. People would say, well, it actually increases your HDL. There's some evidence of that. It also increases some other things. For example, me personally and most of my patients, it tends to increase your body weight. One of the things it does is it decreases your inhibitions, and it takes a little bit of discipline and inhibition to manage a healthy weight. Any kind of addictive substance, and alcohol is addictive. Excuse me, is addictive. A regular use of it can be dangerous. For those of us with atrial fib, they've done some good science coming out just over the past year or so, showing that even these lower amounts, like a drink a day, may cause a little bit more increased risk for atrial fib. My high Hemi, $25. Thanks for the house call. I appreciate that so much. Thank you very much. Bart, I just watched an interview yesterday with Malcolm Kendrick. I got to go check that out. Can you replace aspirin with high dose omega-3? It's interesting. A lot of people ask that, and I think it has to do with, excuse me, I think it has to do with the fact that fish oils have been shown to decrease clotting, and that's the mechanism for baby aspirin. I haven't seen anything on it. I've wondered about that myself, but again, I just haven't seen significant scientific evidence supporting it or poo-pooing it, denying it. Asma Ben Laj, hi doc, can we trust all the medical publications about statins? What was the term? Trust but verify? I think we all have to make our choices. Are you going to trust but verify, or are you going to trust no one? I think we all have, no matter whether you approach the first one with trust or not, I think we all have to verify. You clearly have to, and it's unfortunate, but science can be, as I said, it can be a little bit confusing. Bob Harper, thank you, Leo. Yes, Bob Harper is that fellow who had a heart attack and came out and said, yep, I had a heart attack. I was a well-known fitness nut, and it was LP(a). Got it from my mom. ECT Global, does atherectomies work? I think we covered that earlier. Man, we're getting a lot of that. Freedom Fox 1, Dr. Brewer, do you want to learn about the Pendulum brand probiotic? If you want to learn about it, Kevin Rose podcast is a great interview. I will tell you, I'm going to be jumping from this into a very full day of patients, and I got return a couple of phone calls, so I'm clearly not going to get to that today. But if you'll send that to Michelle in our group, I will maybe take a look at it one evening. John Tocho, 116 watching and only 47 thumbs up. John, thank you so much. I appreciate you bringing up that point. You know, a lot of folks have made actual financial contributions with the super chats, and I really appreciate that. But it doesn't cost anything at all to do a thumbs up. And even more importantly, if you put the connection, refer this to your Facebook site or one of your other social media, like Twitter. When people come in from Facebook or Twitter to see one of these, it makes a big, big difference in terms of the AI. John Chiula, what's the best general advice you have to create a stable cardiac plaque environment? Well, again, John, Joseph, you'd have to watch this channel. Lifestyle is king. You can't medicate, you can't stent, you can't bypass your way out of a lifestyle problem. Diet is the most important thing in terms of lifestyle, both in terms of keeping your body fat down, exercise to keep your muscles increased, decreased muscle mass among 60 years old and older is a big, big deal. And knowing how well you metabolize carbs. Covered that a couple of times today, and we will continue to shout that from the mountaintops. And John Tocho is helping us remind you so you can help us shout that. What's an ARB? Oh, okay. So ACE inhibitor, angiotensin converting enzyme inhibitor, and ARB is angiotensin receptor blocker. Both of them decrease angiotensin. Angiotensin is something that causes an increase in blood pressure, and it works in the kidneys. So one of the things they found, they developed these medications to manage blood pressure. What they found is they actually protect the kidneys. One of the biggest areas to get problem and damage with diabetes is kidney disease. In fact, by far the number one cause of kidney disease is diabetes. Also related to high blood pressure, related to all the cardiovascular diseases. When you look, there's a lot of discussion and debate about the common denominator in chronic disease. And again, it appears to be prediabetes. So I hope that answered your question. Winona, what are some of his allies? I think that might be some dogpiling. I've heard Freedom Fox. I've heard that some of the ARBs can improve insulin sensitivity. Since you prefer ACE inhibitors, I'm guessing there's not a particularly significant effect. Correct. Yeah, I would not really help. I would not depend on an ARB for insulin, for improving insulin sensitivity. Thank you. It was a great comment, great question. Vagabond Sojourner. Annatto tocotrienols and GG are reported to be excellent antioxidants and inflammation blockers, I'm assuming. The book Behind the Truth About Vitamin E, Bernie Tan, PhD. Any thoughts? There's, antioxidants, it's a big, big issue. It created the whole antioxidant supplement craze, which is a multi-billion-dollar industry now. And all that has to do is the mitochondria. And huge topic. Are those the only anti-inflammatories, antioxidants? No. Is antioxidant the same as anti-inflammatory? Yes, for our purposes, it is. And the engineers, the mechanics call that oxidation rust. And if you don't know what the connection of what I'm talking about, take a look at some of my inflammation videos. ProTick Remedy just had my first calcium score. I guess I'm fortunate that I went low carb about a year ago and stabilized it. I'll be calling. We'll be looking forward to meeting you, ProTick. Thank you so much for sharing. Max Bet just got home from the emergency. MI, myocardial infarction, heart attack, new drugs and changes. Start ticagrelor, Brilinta, 90 milligrams. That's another one of the anti-clotting drugs. Increase Crestor to 20 milligrams from 10. And doc, given what I just I'm getting concerned. I'm not sure what your question is, but thank you for sharing the ProTick Remedy, the $20 super chat. Thank you so much, ProTick. Again, as we said before, these super chats, they may seem not a huge amount, but they make a difference. They really, really do. Thank you so much. And again, they help us get that information out all over the world. Burhan Uden, I wrote my questions, but didn't see. I haven't seen your question yet either, Burhan. PT Core, oops, didn't mean to do $9.99, just low tech. Send a super chat correctly. Well, $9.99 is great. Thank you anyway. Vicky Rowley, thanks for touching on your choice not to test for COVID. I so agree. What's the point? Also, thanks for all of your content. Thank you so much, Vicky. Appreciate that. Winona, let me see. We may get to the end of the questions here. David Dombrowski, The Personalized Diet, written by Aaron Siegel and Aaron Illinois. The book explores the dramatic differences of food reactions across individuals. Well, there's no question we are all an N of one, and we all do react to foods differently. But there's also no question, by far, the number one food-related issue that impacts the topic we're talking about, heart attack, stroke, number one cause of death, number one cause of disability, is prediabetes, not being able to metabolize carbs. Danny Wickersham, how about a quick note on artificial sweetener? Does it affect inflammation? Danny, go to our show last week, and we covered that whole topic. And I covered that a little bit in the introduction. There's some evidence that at least a couple of them do a little bit, like sucralose. But there's not a lot of evidence. There's clearly a lot of evidence that they don't do nearly as much damage as many people would like to think. Old Roscoe, Oklahoma Blood Bank, and probably others, or all of them. New COVID antibody tests. Not sure what you're saying. Vicky Rowley, Fort Worth West Side. How can I reach you? I'm in Arlington. Matthew Heyman. GFR, that's a glomerular filtration rate. That's kidney function. At 78, I think 78 years old at 40 GFR, which is not a great GFR, kidney function. No signs of protein in urine, but didn't do a micro screening. Is that also another reason to use lovastatin over rosuvastatin? Not so much. Meds for preserving kidneys, blood pressure is good. The major thing is find the root cause first and deal with that. In most cases, it's prediabetes or diabetes. ET himself with a couple of double thumbs up. Thank you so much, ET. Fort Worth, thank you for the show, Ford. Take care. See you next week. Thank you, Fort Worth. ABC, how fast calcium score doubles. It really depends on what you've got going on. And don't overthink the calcium score. If I've got one, I've got dozens and dozens of people who've come to me with a positive calcium score, gotten their act together, improved their lifestyle, went back to get another calcium score because they knew they were better off. They'd lost 30 pounds, 40 pounds, 50 pounds. And instead of getting a decreased calcium score, it increased dramatically. That's what I told them to expect. If you have a question about that, that's for another video. Bit2 424. Hey, doc, just got a calcium score of 0, but I have strong symptoms of angina. Do you think I should get an angio done? I wouldn't do an angio. We're going to cover that specific topic in a couple of weeks. There's a lot of people that would say, if you have a 0 calcium score, you don't need to do anything. The reality is there is some risk, and that risk is that you have plaque, but it's all soft, non-calcified. And the question is, just how much risk do you have, and what do you do about it? Jan Ling, if you were adhering to a very low-carb diet plus good lifestyle and therefore had low inflammation, would high LDL still be a risk factor? Well, again, we had Dave... I'm blanking on his last name. The lean mass hyper-responder guy, Dave Feldman. We had him on the channel a few weeks ago, and he was making the point that for some people, improving your lifestyle, decreasing your carbs actually result, and decreasing your body fat actually results in increasing LDL. Many places, even Harvard, Mayo, the standard purveyors of medicine are beginning to recognize this now too. So it's just like everything else. It's not always what it seems. Max Bet, thank you, Doc. Freedom Fox, you suggested I send a link through Michelle. Where can she be reached? Michelle is at 859-721-1414. That's 859-721-1414. And if you go to our website, there's a place to contact Michelle by email. Thank you so much for your interest today. We've had a lot of participation. I have got to go see some patients. Thanks again. Bye-bye.